When I first started working in these fields, patients or families didn't have much control over decisions at the end of life. Now they have much more control. Doctors talk about shared decision-making as opposed to their decision-making. So in some ways it's gotten better. But what it hasn't gotten better in is making good decisions about value, the value of interventions at the end of life. So we have lots of interventions that they're what I call high cost, low benefit interventions. What's gone wrong is that for a variety of reasons, we use a lot of very high cost but very low benefit interventions at the end of life. You know, the classic case nowadays are these new cancer drugs, which extend life for only a few months in most cases, but at a cost of several $100,000. Americans aren't very enthused about rationing care. Now, they like to deny that it happens. They like to say that if it does happen, it shouldn't. And of course, needless to say, then there's no good public debate about how to do it. It's inevitable to do it. The only way to avoid some rationing of care would be to spend would be basically to spend virtually all our resources on health care. It would be to give everybody every bit of care that might have some benefit, no matter how small that benefit was and no matter how expensive. And that not only isn't possible, but it doesn't make any sense because we would have to give up too many other things that would provide us more benefit. I think long term, what will fix it is a change in the public's attitudes. In many European countries, there's also resistance to rationing, but there's less resistance. There's less resistance because they're dealing with a national health care system that they can see. Britain's a good example of this. They can see serves all the population. It's a public benefit, a public good. They spend less than half as much per capita on health care as we do, and they have just as good health outcomes as we do. So changing the public attitude from let me get as much of this as I can for myself to this is a public good that we need to conserve the resources for, and we need to use them in a sensible way. Now that change in attitude is a long-term process. It's not a short-term process. At the end of life, people often have greater difficulty in giving up, in no longer using resources. And so you hear this notion, particularly from families, I want everything done. And implicitly there, or sometimes explicitly, don't worry about the cost, right? So what happens is the denial of making judgments about what benefits do we get from what we're spending. The denial of that is more powerful at the end of life. People are afraid at the end of life. We say we're a rich country, we don't need to ration. We say, especially at the end of life, money should be no object, and so forth and so on. So we have the denial of the need to ration. We also have the view that it would be wrong if it happened. So needless to say, we don't like to face up to the decisions. They get made sort of under the table. What we need to do is to, and I don't mean to make this sound easy at all, what we need to do is to set up practices, mindsets, so that people see that just like every place else in life, we should look and see, are we getting something that's worth what we're paying for? And frequently at the end of life, of course, we're not getting something that's worth what we're paying for. We're not even getting something that patients want. So we need to put in place practices which enable us to better make those judgments. Now the judgments are terribly hard at the end of life. Just because it is the end of life, we have a lot of conflict and emotional turmoil with regard to it. So it means on a long-term basis, we need to be better at doing what we do in all the rest of our life, which is You know, when I go to a restaurant, when you go to a restaurant, we look at the prices on the menu, right? And ask, is it worth it to get the oysters or whatever? And we are forced to do that rationing, of course, because we have to pay the bill at the end of the meal. And that's true of virtually everything else we consume. It's not true of health care, and that's one of the reasons that insurance makes rationing so difficult. We need to get people to better understand something that you asked earlier, namely that the growth of Medicare spending is simply not sustainable. And it's not even good for us. That is, we're giving up so many other things that we could be spending that money on, which would provide more benefits. It's even unethical not to ration, because what it means is that the government can't fulfill other ethical responsibilities it has. So I like to say it's impossible not to ration, it's irrational not to ration, and it's unethical not to ration. It's much more difficult for the decisions to be rational because of all the emotions that are involved. Part of the doctor who's been caring for this patient, the part of the family, and part of the patient. So the alternative of who decides, to just take the example of Great Britain again, the National Institute for Clinical Excellence, NICE, makes a recommendation to the National Health Service, which serves the whole population, and then NICE makes a decision that we will not pay for this. Now that means that patients can turn around and say, if they have the resources, which many don't, but, well, I'll pay for this out of pocket. And of course that raises equity issues because most people won't be able to afford to pay for it out of pocket. So the rich will get it and the poor will not. And we have not been willing to we've not been willing to acknowledge that we're going to distribute health care on the basis of ability to pay. We do it a lot, but we're not willing to acknowledge that that's the way we want to do it. So turning around and making the coverage of the cost out of pocket for the individual has serious ethical and equity problems. Basically, there's two things we want out of our healthcare spending. We want to get as much health benefit as we can, given the resources we put into it. And the other thing we want is for those benefits to be equitably or fairly distributed. Those two things can sometimes come into conflict. So, for example, we might think that we want special concern for the worst off individuals, those who are sickest, and we're willing to even forego some overall health benefits in order to ensure that the sickest are treated. And in fact, if you look at studies of real people's attitudes, they reflect exactly that view. So there's two concerns. One is good value for the money we're spending, as much health benefit as we can get, but also that health benefit needs to be fairly distributed among the population. And that's what we want to ensure. Now, the equity aspect is, of course, more complicated, but that's an important piece of ordinary people's concerns about health care. If they didn't have that concern, then we wouldn't worry about some people not having health insurance. We'd say, too bad. Some people can't go to symphony orchestra concerts, and we don't think that's a great ethical failing. I think that there shouldn't be any strict age cutoff, so that you would say no more end-of-life care, no more extension of life care beyond 80 or whatever. That doesn't make sense because sometimes the extension of life might be long and might be very cheap. There shouldn't be any age cutoff of that sort. On the other hand, if you ask how strong is somebody's claim, say, to have an end-of-life intervention, perhaps an organ transplantation that they'll die without, then I think if they're much younger, they have a stronger moral claim to get it than if somebody's 75. Because if I die at 35, fortunately I can no longer do that, but if I die at 35, I've been denied much more of what I could get from healthcare, namely additional years of life. And so I ought to have priority over a patient who's 65. So age can be relevant in some decisions, but it shouldn't be an arbitrary cutoff.